practice focus on hypertension and diabetes.
Well, welcome again. Bismillahirrahmanirrahim. I'd like to share with you our dialysis registry on the year 2018 that was done by the Egyptian Renal Data System, a chapter of the Egyptian Society of Nephrology and Transplantation. We have chosen universities and ministries, center categories, and we included more than 2,000 patients from the universities and over 4,600 patients from the ministry, with a total of 6,757 patients. There were 21 university hospitals and 53 Ministry of Health hospitals. There was a lot of pressure and effort and follow-up, but finally the response was 100%. And 17 governorates were represented in this data submission. And the results, as you can see here, the males constituted 58% of the population, and the age range between 45 and 65 years constituted half of our population, dialysis populations. And we had many outcomes, including virology, anemia, CKD, MVD, comorbidities, vascular access, and dialysate. But what I'd like to linger at now is the original disease. In our study, hypertension was found to be the most important cause, or the first cause of CKD in Egypt, accounting for 38% of the cases, and the next common is diabetes, accounting for 18% of the cases. And this was a previous study by Professor Barsoum showing again that hypertension was the most common, occurring in 35%, but at that time the next common was the unknown causes, and the diabetes was the third cause. The USRDS data 2011 showed that diabetes is the commonest cause of end-stage renal disease, and hypertension follows. So hypertension, uncontrolled hypertension is a risk factor for developing CKD. As we've just mentioned, it's the first leading cause of end-stage renal disease in Egypt and the second in the US, and is associated with more rapid progression of CKD irrespective of the cause. And it has been reported to occur in 85 to 95% of patients with CKD, which means that in the late stages of CKD, it is very likely, probably, we'll find patients having hypertension. So this does not mean that hypertension is the cause, and because we know well that hypertension may cause CKD, but also CKD may cause hypertension, and it's very important that we know which started first. So hypertension damages the vessels not only within the kidney but also throughout the body. And to say that this patient has hypertensive nephrosclerosis, he has to have a long-term essential hypertension with evidence of end organ affection like hypertensive retinopathy and left ventricular hypertrophy, or to have minimal proteinuria and progressive renal insufficiency with no evidence suggesting an alternative diagnosis. Now, you can see here malignant nephrosclerosis with thickening of the intima, lumen narrowing, and onion skin appearance. That's in the arcuate artery, and in the arterioles you get fibrinode necrosis and cellular reactions and thrombosis. And then you end up with the glomerular tufts that are shrunken and glomerular sclerosis with complete obliteration of the capillary loops, and you get glomerular ischemia. And just like any chronic kidney disease, when 50% of the total number of nephrons are lost, you get adaptive heart filtration, proteinuria, and tubular interstitial fibrosis, secondary SGS, and you end up with end-stage renal disease. So knowing that this is the fate of our patients, and knowing that this is the commonest cause of CKD in Egypt, what should we do about that? Well, the first thing and the best thing is prevention, which means that we have to educate people to maintain healthy weight, exercise regularly, eat a healthy diet, reduce sodium in the diet, quit smoking, cut back on caffeine, manage stress, and monitor blood pressure. If we cannot do that, we at least have to do early control, and awareness is very important. You know that hypertension has no signs or symptoms. It has no alarming symptoms. So this study here from the US, RDS, it shows that awareness has been improving over the years, and that in the year 2011 to 2014, there were 22.6% of patients that are unaware they have hypertension, 5.8% are aware but they're not treated, and 43.8% are treated but uncontrolled, and only 27.8% are aware, treated, and controlled, and that's in the US. So it's only 1/3 of the patients that are controlled. What do we do for that? Here we have the World Kidney Day, which is present all over the world, and we started to celebrate this day in Egypt since 2007. Well, actually, we should be spreading awareness all the years through, but this particular day, we screen for diabetes, hypertension, body mass index, and if they found to be present, then we go on for kidney functions and urine analysis. And this is done with the help of young doctors, and I think this is the responsibility of each and every one who calls himself a nephrologist to spread awareness through sports events, TV, radio, newspapers, seminars, to approach universities, schools, and factories, and neighbors, and any group that we can have access to. This is the kidney walk for awareness, and we go to cities and we teach about healthy lifestyle, how important it is to exercise and to drink water, and we give public seminars, we listen to the people's questions, and we also can have some entertainment. And then you should make your patient understand that medications are forever, that receiving medications is not enough and follow-up is essential, and should understand that blood pressure should be brought to target, not just to be a little bit reduced. And just to cut a long story short, this is the latest guidelines from the European Society of Cardiology and Hypertension. And you can see here that the targets that is there for patients with hypertension is to reduce the blood pressure to 130 millimeter mercury systolic and lower if tolerated, but not to go below 120. And this applies to diabetes, coronary artery disease, strokes, but if you look at the CKD patients, the recommendation is to go to target 130 or lower if tolerated, but not doesn't say to go below 120. This also applies to the older group of patients, and for the diastolic hypertension, it has to be reduced below 80 and 270. And the reason for that is that in CKD patients with hypertension, aggressive blood pressure production may increase the risk of cardiovascular events. And if you look at these different studies, the last one here was 651,000 patients showing a J point of less than 120 over 70. Other studies showing systolic blood pressure J point of less than 130, and others less than 110 over 70. And that's we call it the U-shaped curve that we have for almost all aspects of our lives. And finally, we have to include RAS blockade whenever possible. Of course, there is concern about the use of ACE inhibitors and ARBs in our patients with impaired kidney functions. And if you're not going to follow your patients, you better not choose them. Because these are the patients, actually, who are going to benefit most from using the RAS blockade, especially if they have proteinuria. So in order to do that, we have to stop diuretics temporarily, avoid non-steroidal anti-inflammatory, and exclude bilateral renal artery stenosis, and we initiate at a low dose and titrate up as necessary, with monitoring serum creatinine every 3 to 5 days with each change. And if the rise is less than 30 of baseline, we continue. If it is more than 30, we stop. Otherwise, we continue. So finally, and that's what we do, these are recommendations from the European Society of Cardiology and Hypertension, is to start first with RAS blockade together with either calcium channel blocker or a diuretic in a single pill. And the second step will be to use the three together in one pill, RAS blockade plus calcium channel blocker plus diuretics. And the third step is to add spironolactone or other drugs like alpha blockers or beta blockers. And of course, the beta blockers can be considered at any treatment step when there is specific indications, like in the presence of heart failure, angina, post-myocardial infarctions, atrial fibrillations, or younger women or planning for pregnancy. Now the second common disease that we have is diabetes, and if you look here, you will find that this combination of diabetes and CKD, which appears here in in black, is associated with the worst cardiovascular outcomes in all aspects: congestive heart failure, acute myocardial infarctions, and so on and so forth. So again, we have to spread awareness, and again, we have to screen our patients with diabetes. We should measure the creatinine annually, not just the creatinine. We have to estimate the GFR annually, and we have to categorize the degree of albuminuria by measuring the urinary albumin excretion annually. And this is just to show you that diabetic nephropathy produces fast renal decline, and we call it fast when the eGFR slope is less than -15, or the time to onset of end-stage renal disease is 2 to 6 years, and we call it slow when it is equal to or more than -5, or when time to onset is 20 to 45 years, and of course in between you will have the fast and the moderate. And if you look here, this is the fast, this is the moderate, and this is the slow, and you can see that diabetic patients are all in the fast track, except those who initiate treatment early. So the first recommendation here is to start early with intensive control of blood glucose, and there are many studies indicating the importance of the good effect of intensive control on microvascular complications. And if you look to these blue areas, this is where the improvement in microvascular complications persisted even years after the study was stopped. And maybe because of the developing of metabolic memory, but this was consensus for all studies. For cardiovascular disease, there was no great effect, and for mortality, there was only one study, which is the ACRO study, which showed that a strict control is associated with increased mortality. And the reason for that is that aggressive treatment was given late in the course of diabetes, a point where the patients are liable to hypoglycemia. And again, this shows another U-shaped relationship, which shows that there is increased incidence of the risk of death when hemoglobin A1C level is below 6.5 or above 8. For this reason, the recommendation target hemoglobin A1C to be 7% to prevent and delay progression of microvascular complications, and even lower, but definitely not going below 7% in those patients at risk of hypoglycemia, and even going above 7 in individuals with comorbidities or limited life expectancy, which means that we have to individualize our treatment. Well, the second important point is to choose a drug with renal protective and cardioprotective effect. We have a big list of drug armamentarium, but what I'd like to speak about now is the SGLT2 inhibitors. That if you look here, this is the decline in GFR in patients, diabetic patients who are not treated, and the red line is the decline which occurs when they are treated, and the yellow line is when they are given as well RAS blockade. And look at the green line. This is when SGLT2 inhibitors are added, and you can see how it does reduce the deterioration in kidney function. So this is really a good drug, and it works by lowering the threshold at which glucose is excreted from 2050 to lesser levels, and so of course inhibiting glucose reabsorption from the proximal tubules by inhibiting the sodium glucose cotransporter 2, and so more glucose is going to be excreted in urine, and this is going to result in decreased as well in body weight, and of course more sodium will reach the distal tubules and the macula densa and will inhibit the ROS system, so it's going to be also associated with decreased hyperfiltration, decrease in the blood pressure, and there's going to be a reduction in uric acid and increase in autophagy. Many studies are there on SGLT2 inhibitors addressing the outcomes, and we have here examples. We have the EMPEREX study of empagliflozin, which is the Georgians, and it does show its effect on the cardiac and renal outcomes, that's beneficial effect. And this is the dapagliflozin and the DECLARE, which is the Forxiga. And again, you can see the beneficial cardiovascular and renal composite endpoints. And this is also the canagliflozin and the credence. And all these studies were done on a big number of patients. And again, it shows that they are better used for the cardiovascular outcomes and the renal outcomes. But you have to take care that you should not use dapagliflozin at a GFR less than 60, and you should not use canagliflozin and empagliflozin at a GFR less than 45. So below 45, you cannot use any of those. So well, the notion is that you better start early, or otherwise you're not going to be able to start at all. Now we come to GLP-1 receptor agonist, and they work by slowing the gastric emptying and stimulating the pancreas to release insulin and suppressing glucagon secretions. They have many pleiotropic effects affecting different body systems, and on the kidney there is increased diuresis and natriuresis. At the level of the efferent arterioles, they inhibit endothelin and they inhibit reactive oxygen species and angiotensin II, and they reduce the vasoconstriction, so they improve the intravascular hypertension, intraglomerular hypertension. And again, there are many studies, and this is the liraglutide or the Victoza, and you can see here the leader study showing improvement in primary outcome and cardiovascular outcomes, and there are other studies showing a beneficial effect of liraglutide and the kidney with a reduction in renal albumin to creatinine ratio when compared to placebo. And again, you have to take care that these drugs cannot be used, can be used only in mild renal impairment and should not be used at later stages. But what the good thing is that in the pipelines there are other drugs that have been developed. We have the dulaglutide, which can be given once weekly, and its exposure is not altered in patients with various degrees of reduced kidney functions. And the REWIND study shows that it has a renal protective effect. This was in the year 2017. And then we have the semaglutide and the SUSTAIN-7 study, again showing it is even superior to dulaglutide in terms of glycemic control and similar reduction in body weight and similar safety profile. And again, this is the SUSTAIN-6, which showed this beneficial effect on the cardiovascular endpoints. So these two drugs, they can be used at all stages of CKD. What about the DPP-4 inhibitors? Again, there are studies on cardiovascular outcomes, and they found to be neutral. But this is a study of enagliptin showing that a nephroprotective effects when measuring the microalbuminuria, macroalbuminuria, and worsening CKD. And again, about the doses, we have to know that the only one where there is no dose modifications is the linagliptin, whereas we have to reduce the dose twice, the sitagliptin, from 100 to 50 to 225, and it is reduced once in vildagliptin from 100 to 50. So, in conclusion, Mr. Chairman, registration is the only way by which we can know what is happening with our patients and hence set our priorities. Hypertension and diabetes are the most common causes of end-stage renal disease, and hence they should be given great attention. Spreading of awareness is of paramount importance for prevention and early control of the disease. In hypertensive patients, blood pressure should be brought to target, considering that one size does not fit all. And in diabetic patients, early, strict glycemic control and choice of drugs with renal protective effects could delay progression of end-stage renal disease. RAS blockade is a cornerstone in hypertension and diabetes, and treatment should be individualized with the notion of doing no harm. And thank you very much.
Thank you very much, Dr. Ramay, for the excellent lecture. Any comments? No comments. Thank you very much.
Now the last presentation in this session is Professor Dr. Gamal Madi, Professor of Nephrology at Shams University, talking about the vaccinating the patient with end-stage kidney disease.
I would like to present one of the missed topics in nephrology here in Egypt, and who are underestimating the vaccination in the patient with chronic kidney disease. But it has very important background for the life of the patient. CKD patients are at increased risk of incidence and severity of infections because they are immunocompromised. Infections are the second cause of death in CKD patients after the cardiovascular causes. It accounts for around 8% of total mortality in this population. Successful renal transplantation does not solve the problem of infection due to the use of immunosuppressants. Of course, the metabolic complications of uremia causing abnormalities in the monocyte and neutrophil function, antigen processing, antibody formation, and cell-mediated immune responses. People on dialysis have a greater chance of getting infection. Some of these infections are life-threatening. Hemodialysis patients have been identified by the Centers of Disease Control and Prevention, CDC, and a high-risk population for which vaccination is recommended. At the time of admission to the outpatient for hemodialysis, we must assess the vaccination status of the patient, especially for hepatitis B, pneumococcal pneumonia, and influenza if applicable. If the patient refuses, this refusal of the vaccine will place him at risk of contracting hepatitis B virus infection, places the patient at risk of becoming a chronic carrier of hepatitis B, and subsequent hepatocellular carcinoma and liver cirrhosis,